Wide complex tachycardia. Dr. Pradeep Soykumar. Definitions. Wide QRS complex tachycardia is a rhythm with a rate of greater than or equal to 100 dm and QRS duration of greater than or equal to 120 ms. VT, 3 or more consecutive ventricular beats with rate of 100/minute or more. SVT tachycardia requiring participation of structures above bundle of his. LBBB morphology QRS complex duration greater than or equal to 120 ms with a predominantly negative terminal deflection in lead V1. RBBB morphology QRS complex duration greater than or equal to 120 ms with a predominantly positive terminal deflection in V1. Why QRS is wide. A widened QRS, greater than or equal to 120 ms, occurs when ventricular activation is abnormally slow. Arrhythmia originates outside of the normal conduction system, ventricular tachycardia. Abnormalities within the His-Purkinje system, supraventricular tachycardia with aberrancy. Pre-excited tachycardias, supraventricular tachycardias with antegrade conduction over an accessory pathway into the ventricular myocardium, SVT, 20%. VT, 80%. Stuart Harvey, Ann and Turnmed 1986. Causes of wide QRS complex tachycardia. Supraventricular tachycardia. With persisting BBB. With BBB due to heart rate, aberrant conduction. Antidromic tachycardia in WPW syndrome. Ventricular tachycardia, other causes. Hyperkalemia acidosis antiarrhythmixia, IC. Ventricular pacing. Functional bundle branch block. Functional aberration results from sudden change in cycle length when parts of the His-Purkinje system are partially or wholly inexcitable. Functional RBBB more common. Linking phenomenon. Mechanism for perpetuation of functional anterograde bundle branch block due to repetitive transeptal retrograde concealed penetration by impulses propagating along the contralateral bundle. Linking, a dynamic electrophysiologic phenomenon. In macro-reentry circuits, Michael H. Lohmann et al., Circulation. 1985 71 to 254 to 265. Linking phenomenon. AVRT orthodromic AVRT-antegrade conduction, of node. Retrograde conduction, accessory pathway. Wide QRS is produced only if aberrant conduction. Rate-related or pre-existing BBB. Antidromic AVRT-antegrade conduction over the accessory pathway and retrograde conduction over the avenue node. AVRT. Mohiam fiber-mediated tachycardia. Antegrade conduction, Mohiam pathway. Retrograde conduction avenue node. LBBB morphology. Left axis deviation. Pre-excitation during sinus rhythm is uncommon. Bundle branch reentrant VT. RBBB morphology wide QRS tachycardia. VT. Structurally normal heart. LVD VD. Fascicular VD. Abnormal heart. LV myocardial VD. Bundle branch reentrant VD. SVT. SVT with pre-existing RBBB. SVT with functional RBBB. LBBB morphology wide QRS tachycardia. VT. Structurally normal heart. With VT. Abnormal heart. Right ventricular myocardial VT. ARVT. Mohiam fiber-mediated tachycardia. SVT. Mohiam fiber-mediated tachycardia. SVT with LBBB. Unique clinical challenge. Diagnosing the arrhythmia is difficult. Diagnostic algorithms are complex and imperfect. Urgent therapy is often required. Patients may be unstable at the onset of the arrhythmia or deteriorate rapidly at any time. Risks associated with giving therapy for an SVT to a patient who actually has VD. SVT versus VT clinical history. Age. Greater than or equal to 35 years VD, positive predictive value of 85%. Underlying heart disease. Previous ME 90% VD. Pacemakers or ICD. Increased risk of ventricular tachyarrhythmia. Medication. Drug-induced tachycardia torsade points. Diuretics. Digoxin-induced arrhythmia, digoxin, greater than or equal to 2/L or normal if hypokalemia. Duration of the tachycardia, SVT is more likely if the tachycardia has recurred over a period of more than 3 years. SVT versus VT. Avenue dissociation. Canon waves. Variable intensity of S1. Termination of WCT in response to maneuvers like Valsalva, carotid sinus pressure, or adenosine favor SVT. Maneuvers. The response of the arrhythmia to maneuvers may provide insight to the mechanism of the WCT. Carotid sinus pressure enhances vagal tone, depresses sinus and avenue nodal activity. Carotid sinus pressure. Sinus tachycardia will gradually slow with carotid sinus pressure and then accelerate upon release. Atrial tachycardia or atrial flutter, the ventricular response will transiently slow. The arrhythmia is unaffected. Paroxysmal SVT frequently terminates with carotid sinus pressure. VT. Unaffected by vagal maneuvers such as carotid sinus pressure or Valsalva. May slow or block retrograde conduction. Exposes avenue dissociation. Rarely Vermont terminates in response to carotid sinus pressure. Laboratory tests. The plasma potassium and magnesium concentrations, hypokalemia and hypomagnesemia predisposed to the development of ventricular tachyarrhythmias. Digoxin, quinidine, or procainamide levels to rule out drug toxicity. Chest X-ray evidence suggestive of structural heart disease. Evidence of previous cardiothoracic surgery. Presence of a pacemaker or ICD. Rate. Limited use in distinguishing VT from SVT. When the rate is approximately 150 beats per minute, atrial flutter with aberrant conduction should be considered. Ventricular rate greater than 200, suspect pre-excitation tachycardia. Regularity. Marked irregularity of RR interval occurs in atrial fibrillation, AF, with aberrant conduction and polymorphic VT, axis. A right superior axis, axis from -90 to ±180 degrees, northwest axis, strongly suggests VT. Sensitivity 20%, specificity 96%. Exception antidromic AVRT and Wolff-Parkinson-White, WPW, syndrome. Compared to the axis during sinus rhythm, an axis shift during the WCT of more than 40 degrees suggests VT. In a patient with a RBBB like WCT, a QRS axis to the left of -30 degrees suggests VT. In a patient with an LBBB like WCT, a QRS axis to the right of +90 degrees suggests VT. QRS duration in general, wider QRS favors VT. In a RBBB like WCT, a QRS duration greater than 140 ms suggests VT. In a LBBB like WCT, a QRS duration greater than 160 ms suggests VT. In an analysis of several studies, a QRS duration greater than 160 ms was a strong predictor of VT, likelihood ratio greater than 20 to 1. A QRS duration less than 140 ms does not exclude VT. VT originating from the septum or within the His-Purkinje system may be associated with the relatively narrow QRS complex, concordance. Concordance is present when the QRS complexes in all 6 precordial leads, V1 through V6, are monophasic with the same polarity. Either entirely positive with tall, monophasic R waves, or entirely negative with deep monophasic Q complexes. If any of the 6 leads has a biphasic URS, QR or RS complexes, concordance is not present. Negative concordance is strongly suggestive of VT. Exception SVT with LBBB aberrancy may demonstrate negative concordance. Positive concordance also indicates VT. Exception, antidromic AVRT with the left posterior accessory pathway. Presence of concordance strongly suggests VT, 90% specificity. Absence is not helpful diagnostically. approximately 20% sensitivity. Higher specificity for positive concordance compared to negative concordance, specificity 95% versus 90%. Negative concordance. Positive concordance. Avenue dissociation. Avenue dissociation is characterized by atrial activity that is independent of ventricular activity. Atrial rates lower than the ventricular rate, diagnostic of VT. Atrial rate that is faster than the ventricular rate, SVTs. Absence of avenue dissociation in VT. Avenue dissociation may be present but not obvious on the ECG. The ventricular impulses conduct backwards through the avenue node and capture the atrium, retrograde conduction, preventing avenue dissociation. Dissociated P waves PP and RR intervals are different. PR intervals are variable. There is no association between P and QRS complexes. The presence of a P wave with some, but not all, QRS complexes. Fusion beats. Fusion beat produced by fusion of two ventricular activation wavefronts characterized by QRST morphology intermediate between normal and fully abnormal beat. Fusion beats during a WCT are diagnostic of avenue dissociation and therefore of VT. Low sensitivity 5 to 20%. Capture beats. Capture beats, or Dressler beats, are QRS complexes during a WCT that are identical to the sinus QRS complex. Implies that the normal conduction system has momentarily captured control of ventricular activation from the VT focus. Fusion beats and capture beats are more commonly seen when the tachycardia rate is slower. If ALDIC available. Ideal QRS configuration between baseline and WQRST suggests SVT exception, bundle branch reentrant VT. Contralateral BBB patterns in baseline versus WQRST ECGS suggest VT. WQRST complexes narrower than baseline ECG suggest VT. The baseline ECG must have a bundle branch block pattern. Also look for VPC's evidence of prime EQT interval. ECG clues to any other structural heart disease. SVT versus VT ECG criteria, Brugada algorithm. Brugada P circulation 1991. Step 1. Step 2. Step 3. Step 4, LBBB, type-wide QRS complex. SVT. VT. A wave greater than 30 ms. Smaller wave. Notching of S wave. V1. Fast down slow. Of S wave. Greater than 70 ms. V6. Q wave. No Q wave. V1 and LBBB type QRS. True LBBB-RR duration less than 30 msec interval from QRS onset to S nadir less than or equal to 70 msec, 85% of SVTA, VTR greater than 30 msec, QRS onset to S nadir greater than 70 msec, sensitivity 0.78, specificity 0.85, positive predictive value 0.97, notching and slurring of QRS complex myocardial disease. V6 and LBBB type QRS true LBBB monophasic R with slow upstroke VT. QI or Q's pattern. Step 4, RBBB, type wide QRS complex. SVT. VT. RSR configuration. Monophasic R wave. QR, or RS, complex. V1. Or RS greater than 1. RS ratio less than 1. Q's complex. V6. Or V1 in RBBB type QRS. Initial ventricular activation is independent of RBB. RBBB aberration affects only the latter QRS. True RBBB. RR, RSR, R senior, RSR. VT. QR, RSR, monophasic R wave. sensitivity 0.97, specificity 0.88. VTS-VT. V6 in RBBB type QRS RBBB aberration small S wave. QRS or Rs pattern. RBBB type VT. VT from left ventricle LV and RV voltage contributes to S. QRS, RS, Q's patterns seen. RS ratio in V6 rule. RS ratio in RBB type wide QRS tachycardia less than 1, favors VD. Sensitivity 0.73. Specificity 0.79. Positive predictive value 0.9. Josephson sign. Notching near the nadir of the S wave. Suggest VT. Whelan's criteria, QRS width greater than 140 ms, left axis deviation. Avenue dissociation. Configurational characteristics of the QRS morphology. Ultrasimple Brugada criterion. Joseph Brugada, 2010. A wave peak time in lead 2. Duration of onset of the QRS to the first change in polarity, either nadir Q or peak R, in lead 2. If the RWPT is greater than or equal to 50 ms, the likelihood of a VT very high, positive likelihood ratio 34.8. Pava LF, Baraf P, Badem, Arango JJ, Montana L, Murillo CA, and Brugada J. A wave peak time at BI, a new criterion for differentiating between wide complex QRS tachycardias. Heart Rhythm 2010 July, 77922-6. Virek A, Jurag, Zanassi G, Altimos GT, and Miller JM. Virek A, Jurag, Zanassi G, Altimos GT, and Miller JM. Application of a new algorithm in the differential diagnosis of wide QRS complex tachycardia. Yerhart J 2007 R, 28.589-600. AVE algorithm. Criteria looks only at lead AVE. If answer is yes, then VD. 1. Is there an initial R wave? 2. Is there a R or Q wave greater than 40 ms? 3. Is there a notch on the descending limb of a negative QRS complex? 4. Measure the voltage change in the first, VI, and last 40 ms, VD. Is VI, VT less than 1? Virek et al., Heart Rhythm 2008. Sensitivity specificity PPV and PV Brugada 89%, 73%, 92%, 67%. Virek 97%, 75%, 93%, 87%. Virek A, Jurag, Zanassi G, Altimos GT, and Miller JM. Application of a new algorithm in the differential diagnosis of wide QRS complex tachycardia. Yerhart J 2007 R, 28.589-600. Sensitivity and specificity for VT. 88% and 53% by AVE algorithm. VT versus AVRT ECG criteria. Brugada P. Circulation 1991.